So it gives me great pleasure to announce our friend from Russia, Dr. Denis Fedorenko. Please give him a round of applause.
Thank you very much, Alison. So, dear friends, dear colleagues, good afternoon. And thank you very much for opportunity to present our report. It's great honor to me to be here. And dear AIMS Charity, congratulations with your 5th birthday. So it's great. And so let's go ahead. And the topic of my report, the concept of hematopoietic stem cell transplantation and multiple sclerosis based on Pirogov Center experience. And I'm going to discuss the following questions. Beginning somewhat about our center, the Maximov Department of Hematology and Cellular Therapy. Another topic is rationale for the use transplantation for multiple sclerosis with some methodological issues, like what means effective treatment of multiple sclerosis and why HCT is highly effective here, what protocol is one of the most suitable for MS patients, and is this treatment safe, what patient is the best candidate for transplantation, and what is the best time to do it, and what are our long-term results, and is this treatment effective for progressive variants MS, and how to provide the optimal support of transplantation. Also somewhat about our New Life Association and perspectives. The Maximov Department of Hematology and Cellular Therapy was created in 2003, and in 2005 it was named after famous Russian histologist Professor Alexander Maximov, who was a developer of stem cell theory of hematopoiesis. The first transplantation in the department was performed in 2005, and since then more than 4,000 transplantations for autoimmune diseases and hematological malignancies have been performed. Professor Andrei Novik, my boss, was the first chief of the department and the pioneer of this approach in Russia. He performed the first transplantation in Russia in 1999 in St. Petersburg. So since then, we treated more than 2,000 patients with different autoimmune diseases, but mainly with multiple sclerosis, 2,034 patients from 2005 till June 2023. Also, we treated other autoimmune neurological diseases and rheumatic diseases. So another topic, what means effective treatment of multiple sclerosis? This is position of our center. Why HCT is highly effective here? Firstly, we need to ask what is the real opportunity of treatment using standard treatment, conventional treatment? There are two core questions. First one is it possible to cure MS? And second one, is it possible to prevent disability? In the vast majority of cases, unfortunately, no. And why no? Because all standard treatment, all disease-modified drugs are not able to eliminate autoreactive T and B lymphocyte clones. But on the other hand, what means effective MS treatment? So effective MS treatment is to stop MS progression for a long period of time, years, to prevent irreversible CNS damage and critical disability of patient, to improve significantly neurological deficit for a long period of times, and finally, to improve patient's quality of life. Non-effective treatment is aimed at decreasing rate of inflammation, number of size of lesions, decreasing number of relapses. It's important, but not enough. In area, transplantation usually leads to effective treatment goals. So, and it's clear that principally new approach for MS treatment was needed, and this new and old approach, which came from oncology and hematology, is treatment intensification. Treatment intensification is based on dose intensification, increasing summary dose and dose density, and decreasing intervals between doses. So HCT is like a heat, chemotherapy concentration, time and doses. High dose for short period of time is principle of transplantation conditioning. But another important issue is area of toxicity, which is very dangerous. And we should avoid this area, and we need to get into corridor with the best balance between toxicity and effectiveness. And for today, this is a corridor of lymphoablative HCT. So transplantation is very effective because this approach allows to eliminate effectively autoreactive T and B lymphocyte clone, the main target of this approach. Further topic, what protocols is the most suitable in multiple sclerosis patient, and is this treatment safe? I think these questions are very important. And this is our program, and also this is quite common, widely used program. We can see on this picture, we can see traditional longitudinal scheme of transplantation with key points to improve effectiveness and to decrease toxicity of this treatment. And these points are stem cell mobilization, high-dose immunosuppression, monoclonal antibodies, and early and late post-transplant care. So, and on this picture, we can see evolution of our program for multiple sclerosis patients from toxicity to safety and better outcomes, changing our program in these key points. For example, stem cell mobilization from chemotherapy and GCSF to GCSF with steroids, high-dose immune suppression from BAM-BEAM-like conditioning to cyclophosphamide-based and cyclophosphamide and fludarabine-based regimens, and monoclonal antibodies from ATG to rituximab, and early and late post-transplant care from watch and wait approach to personalized approach to rehabilitation, consolidation, and supportive therapy in some cases. Toxicity of transplantation, after analyzing our first result, was quite suitable. The most common side effects were infection like febrile neutropenia, transitory neurological deterioration, mild hepatic toxicity, mucositis, some cases of sepsis, and other infections. Transplantation-related mortality was from 0.2 to 0.5% for old protocols, and now we have 0% of mortality for new protocol based on fludarabine and cyclophosphamide. So, and other topic, what patient is the best candidate for HCT? We have analyzed more than 500 patients with follow-up duration almost 30 months. The patient's characteristic is presented here. And we found that, for example, event-free survival for relapsing remitting multiple sclerosis was significantly higher to compare with progressive group. Also, younger patients with disease duration less than 5 years had much better result to compare with longer disease course. And patients younger 30 years old had better results to compare with patients older age. So factors which improve event-free survival according to our results are early transplantation, I will show it later, younger age, younger 30 years old, disease duration less than 5 years, and relapsing remitting multiple sclerosis. Also, we analyzed some other factors, and we found that factors which do not influence on event-free survival. It's interesting presence of active lesions before transplantation, gender, ATG using, and quality of life before transplantation. So, and what is the best time to do this treatment? How to make a right decision? The concept of transplantation based on MS stage and disability was developed in Pirogov Center, so there are 3 strategies. First one is early transplantation. This transplantation is provided in early stage of multiple sclerosis for patients with low disability. It's important to make a right decision and to assess risk and benefits ratio. This group should have unfavorable factors, high disease activity, lots of relapses per year, spinal involvement. And the goal of this treatment is to prevent irreversible damage of the CNS, to stop the disease progression in early stage, and to prevent patients' disability. Most common is conventional transplantation. Second variant is provided in mid-stage of the disease for patients with moderate disability level, usually when patient fail 1, 2, or 3 variants of disease-modified therapy, And the goal is to prevent the disease progression in patients with some neural damage, to stop further disease progression, and to improve patients' quality of life. And salvage transplantation is quite a responsible option and is provided for very disabled persons with a DSS 7 and higher. And the goal is to stop the disease progression in patients with irreversible neural damage, to save a patient from complete disability, and to improve severely declined patients' quality of life. When we make decision about salvage transplantation, we should carefully analyze all risks and benefits. And of course, in this stage, patients should have inflammation, quick progression. So this transplantation is a kind of last chance to stop the disease. And treatment decision should be made on patient-physician communication, clinical data, traditional neurological assessment, general medical examination, and patient-reported data, which are very useful and important. So like quality of life and symptoms assessment. Support of relatives is also very important here. So when we analyze our outcomes, so treatment outcomes should be based on assessment physician-reported and patient-reported outcomes. We shouldn't forget about quality of life and symptoms dynamics. So according to our approach, we can see that event-free survival of early transplantation was much better to compare with salvage and conventional transplantation group. So early transplantation is quite perspective technology. And so quality of life in early transplantation group, this is SF36 questionnaire. Red diagram is before transplantation, improved significantly, and in 1 year after transplantation reached population norm. Orange diagram is population norm. Quality of life of conventional and salvage transplantation group also improved, but less, not reaching population norm. In whole group of patients, we found significant decrease of frequency 10 moderate to severe symptoms. So we can see red bar, frequency of severe from 7 to 10 using numeric rating scale before transplantation, and blue bar more than 1 year after transplantation. Another question, what are the long-term outcomes of HCT? Is HCT effective for progressive variants of MS? So my colleagues reported about this opinion, and we are on this position, and I will show you our results. There are lots of discussion about degeneration and inflammation, relationship between these two options, and effectiveness of transplantation in progressive variants of MS. But around 15 years ago, it was postulated that pronounced inflammation in the brain isn't only present in acute or relapsing remitting multiple sclerosis, but also in secondary and primary progressive disease. So transplantation causes complete control of immune-mediated inflammation in the brain tissues and resetting of the immune system with the restoration of self-tolerance to autoantigens. So it's possible to imagine that transplantation can be effective in progressive variants of MS, and this is our long-term follow-up results. So 258 patients with relapsing remitting multiple sclerosis, we can see that after HCT, the vast majority of patients with RMS were relapse-free. Mean time until relapse was 30 months, and estimated relapse-free survival at the follow-up of 3 years was more than 90%, 5 years more than 80%, and 7 years also more than 83%. The results are excellent. And estimated progressive free survival, this is secondary progressive multiple sclerosis patients, 160 patients with active disease, and estimated progressive free survival in secondary progressive multiple sclerosis at follow-up of 2 years was 88%, 3 years 87%, and 7 years 76.5%. The results are quite impressive. And quality of life improved significantly as well in relapsing remitting group as in secondary progressive multiple sclerosis. So blue one before and red one 1 year after transplantation. And so important question, how to provide the optimal support of transplantation in routine clinical practice? The rules of success are based on multidimensional approach and specialist cooperation. It's quite important to provide comprehensive pre-transplant examination using all modern approaches, risk factors assessment, patient-based risk, disease-based and treatment-based risks. We need to analyze risk-benefit ratio to try to assess possible prognosis, possible effect, and possible risk. And it's quite important to make decision about further treatment together with patient. Preparation for HCT is also very important. This is infection screening, local infection treatment, and symptoms control. During transplantation, it's very important to be in cooperation with other specialists like neurologists, physiotherapists, nutritiologists, psychologists, cardiologists, and other for indication. It's important to have opportunity to treat patients in aseptic intensive care unit department rooms in case of severe complication. Good supportive treatment is necessary in this period. This is symptoms control, bowel dysfunction treatment as the most common reason of infection, bowel flora translocation, infections control, psychological support, which is very important, nutritional support, and physiotherapy in neutropenic phase in aseptic rooms, especially for very disabled patients. So it's important. Timely diagnosis, prevention, and treatment of complication is extremely important during treatment process. And after treatment, the approach to multidimensional approach and cooperation is also important. This is good supportive treatment, proper rehabilitation using modern technologies, lifestyle changes, psychological support, and risk factors of relapse assessment and prophylaxis, and good symptoms control. So I would like to tell some words about our New Life Association. In 2008, Professor Andrei Novik supported creation of the Patient Association New Life. This association included patients who underwent autologous stem cell transplantation for multiple sclerosis and other autoimmune diseases, and symbol of this association is blue iris. It was patient's choice, and blue iris symbolizes faith, valor, and wisdom when we go through all difficulties. In 2009, New Life Association took part in international symposium, stem cell transplantation and multiple sclerosis. It was first symposium in Moscow, and this approach is very useful. I support it because all modern symposiums should be in cooperation with patients, not separately. And 10 years later, in the first international conference, stem cell transplantation in autoimmune diseases. So totally our New Life team includes more than 1,500 patients from different countries. And some words about perspectives we are developing in our hospital. This is new lymphoablative conditioning regimens to find the best balance between effectiveness and toxicity, HCT and consolidation therapy, tandem transplantation, HCT and intrathecal treatment using immunotherapy or chemotherapy, HCT in combination with other variants of cellular therapy, CAR-T therapy, and new approaches to early and late post-transplant rehabilitation like Locomat, VR technologies, and of course development of new treatment modalities for MS relapse or progression after transplantation. So this is an example of lymphoablative protocol we started to use in our hospital. This protocol is based on fludarabine and cyclophosphamide, and first results demonstrated high effectiveness and safety of this program. And another example is development of treatment modalities for multiple sclerosis, relapse, progression after transplantation. This is second transplantation option. Indication acute multiple sclerosis in more than 1 year after first transplantation. We use another conditioning regimen in combination with intrathecal chemotherapy. First results are not published yet, but first results are very good. And in conclusion, let's enjoy these wise phrases. I love it for inspiration. Only I can change my life, no one can do it for me. In order to succeed, we must first believe that we can. And knowing isn't enough. We must apply. Wishing isn't enough. We must do. And thank you very much for your attention.
Okay, we've got time for some questions for Dr. Fedorenko. I think Karen's got the mic here, so if you raise your hand, and Preeti's got a mic over here as well. So any questions for Dr.
Thank you.
Fedorenko?
Hi. So you talked about having a lot of pre-treatment or pre-assessments before any treatment, etc. Given that you're in Russia and our patients are here, where would that
We
pre-treatment?
provide pre-treatment examination during first 3-5 days in our hospital. It includes like neurological examination and general medical examination. According to international rules, MRI, neurological examination, and heart assessment, and ultrasound, X-ray test, computer tomography for indications. So we can do it in hospital.
So it's just a 3-4 day thing rather than
4-5 days before starting treatment. So first stage is examination, then decision making together with patients and patients' relatives, and start treatment.
Okay. Thank you.
Question here.
You mentioned that there was psychological support as part of the team.
Yes, psychological.
Curious about what that was.
Psychological support is very important because the treatment can be quite complicated, especially when we use corticosteroids. Some people can be depressed with sleeping problem, and this is a part of symptomatic control. We use psychologists and psychiatric service in our hospital. In the case of complication, we provided another option for psychological support is our New Life team, and other patients support new patients. So this is why we work together with association.
Thank you.
And Anastasia, our patient, had transplantation 12 years ago. She is an administrator of our department and helps a lot to in case of psychological problems based on her personal experience.
Okay. Thank you. Hello. Just from one of the things from your slides, could you speak more about the development of treatment modalities for MS relapse or progression after HSCT?
This is second HSCT option. Unfortunately, transplantation is effective not in 100% of cases, and we have a group of patients who relapse or progressed after transplantation, and we developing these approaches. Possible future approaches, CAR-T technology. So we work with the Institute of Immunology in developing this approach for people who relapse or progressed. And second option, we use it now. This is second transplantation in case of acute relapse or progression. So, but we try to provide intensification using systemic chemotherapy with another combination of chemotherapy agents and intrathecal chemotherapy. This is lumbar puncture injections and chemotherapy like in leukemia. Hematologists know what I mean. So we use 3 medications. This is RSC, methotrexate, and dexamethasone.
Thank you for your talk, Denis. Very nice. One of the things that's happened with the EBMT is that your unit is coming to work with the EBMT, and I think that's very important that we all come together and hopefully get thousands and thousands of patients' data into the EBMT registry. Did you want to say anything about that? Because it's vital to advancing the field, and I think you're a big component of the MS data set now, aren't you?
John, thank you very much. I would like to tell you that follow-up observation sometimes complicated. Lots of researchers know about it, especially if patient lives in different countries. So now we are preparing our next result of big group, more than 1,300 patients with a long-term follow-up, and we are going to publish this data to EBMT conferences, 50-year EBMT conference. So thank you.
Thank you very much, Dr. Fedorenko. Excellent. Can we give him a round of applause, please?
Yeah.